Good afternoon. My name is Catherine Paridiso. I'm a doctor of nursing practice. I'm also an assistant professor and the graduate program coordinator at the College of Staten Island, which is part of the City University of New York. I'm privileged to be an adult and psychiatric nurse practitioner, and I'm here today to talk to you about the opioid epidemic, harm reduction, and the nurse practitioner role. Addiction is a disease. So a person doesn't have opioid addiction, alcohol addiction, they have a disease of addiction, and what the choice or what the person is addicted to can vary. So we know people can be addicted to alcohol and drugs and gambling. They can also be addicted to sex and technology now, which is a new thing that we're seeing more of. And I say laughingly that you could be addicted to shopping, but in truth, anybody can be addicted to anything. When it comes to opioid addiction, there's no boundaries of gender, race, class, or socioeconomic status. I live and work with patients who are addicted to opioids. I'm, again, fortunate that I can use my adult and my psychiatric nurse practitioner certificates and licenses to treat those patients. But in the community where I live, we have everybody from, poverty to filthy rich, and our patients cross that gamut accordingly. Every race, every class, it doesn't matter how much money you have, where you live, who you are. We see people with opioid addiction everywhere. And it is a huge problem in the community where I live, but it's a problem everywhere in the country. And I'll get into a little bit of the data later on. When there's opioid addiction in the family, there's a lot of chaos in the family, a lot of chaos in the house. It can destroy any life, any family, any person's finances, and it really can destroy a community. In addition to lost productivity at school and at work, the family conflicts and family violence leads to health problems in the other family members as well. So it's not a disease of one person, it really is a family disease. Because these people lack judgment, they may also engage in unprotected sex. So we do see a lot of STDs and, unfortunately, a lot of unplanned pregnancy. We also see motor vehicle accidents. A lot of patients come to us from the court where they're arrested for driving under the influence, or have an accident and a person is injured, or they commit a crime, and they are diverted to our program, which is, I forgot to tell you that I see patients in the YMCA Counseling Center for Drug and Alcohol Abuse, and patients are diverted to our program from the courts all the time for crimes that they may have been arrested for while using. In the case of homicide, I don't believe that we get those patients. They usually do, they usually are incarcerated because they are documented obvious harm to other people. And then, of course, there's a very high rate of suicide among people who are opioid addicted. The Diagnostic and Statistical Manual of Mental Disorders is the book that the American Psychiatric Association publishes, where all of the diagnostic criteria for all of the behavioral health disorders are listed. This book is very friendly to primary care. You've probably used it if you're a nurse practitioner and you've had to diagnose anxiety, depression, or post-traumatic stress, but also in the DSM-5 is opioid use disorder. So the DSM characterizes it or defines it as a problematic pattern of opioid use leading to clinically significant impairment or distress. So that's the definition of it. But there's criteria that have to be met before you can make a diagnosis. So the diagnostic criteria are that two of the following have to be observed within a 12-month period. So in order to confirm the person as having opioid use disorder, which is the proper word for opioid addiction, opioids are taken in a larger amount over a longer period than was intended. So the person, this is an example of somebody that takes an opioid for pain, thinks they're going to take it for a couple of weeks, and all of a sudden is taking it for a couple of years. There is a persistent desire or unsuccessful efforts to cut down or control opioid use. Opioid use leads to intense cravings, and the cravings are only quelled by taking an opioid. And that is why it is, just like cigarettes or alcohol or anything else, very difficult just to stop cold turkey, or really almost impossible. I've never met anybody who could stop opioids that way once they were diagnosed with opioid use disorder. A great deal of time is spent in activities necessary to obtain the opioid, use the opioid, or recover. So this is the person that has to go out and find it, has to find a way to pay for it, has to sneak to use it, and has to recover from it the next day. Opioids can be pills. It can also be heroin. A lot of times the person will start with, oxycodone pills, and they'll progress to heroin, snorting, and then eventually be taking it intravenously. So all these things take different amounts of time. They progress over different periods, but it's the time issue that's addressed in this criteria. Cravings, I mentioned. Recurrent opioid use resulting in a failure to fulfill major role obligations at work, school, or home. Here, parenting obviously becomes a problem. We do see sometimes, administration for children's services involved because parents get reported if they're stoned while caring for their children. So, there are times when other agencies get involved, but basically it's the inability to fulfill their role obligations in any walk of life. More criteria here. Continued opioid use despite having persistent or recurrent social interpersonal problems caused or exacerbated by the effects of opioids. Important social, occupational, or recreational activities are given up or reduced because of opioids. Recurrent opioid use in situations in which it is physically hazardous. So driving, operating machines, going to work, all of those things. Construction and anything, so that basically is a nice way to say the person's stoned at work and driving. Continued opioid use despite knowledge of having a persistent or recurrent physical, psychological problem that is likely to have been caused by or exacerbated by the substance. So this refers to the person kind of actually knows that they have a problem, but they haven't really been able to seek help. They haven't, help is voluntary, right? You have to check yourself in. So they haven't done that. So that refers to that one. I have to say, in many of these, many patients, I see almost all of these present. But there's always more to the story, right? How does the person get addicted, right? And the pathway in to many people getting addicted in the past was pain management. Once the awareness was raised, let's just go back in time. There was a period of time where providers were told that if they didn't manage their patient's pain, they were horrible. Pain became the sixth vital sign. I'm sure you've all remember or heard about that part of medical history. And people received opioids willy-nilly, all right, and then became addicted very quickly and then couldn't get off. And there is a movie called Dope Sick on Hulu, and there's a book called Dope Sick, and then there's also a book called The Empire of Pain. I would really encourage you to watch that or read it because it's a true story about how the Sackler family knew that the opioids were addicting, put out false evidence that they were not addicting, and encouraged doctors and nurse practitioners to prescribe them. So a lot of people were addicted and a lot of lives were lost because of that. Once that awareness came about and the prescription drug monitoring systems went into place, providers became more aware of and prescribed opioids less. A lot of states have requirements for doctors and nurse practitioners to get educated on opioid prescribing and pain management. So less people are getting them for pain management, but there are times when it's necessary. So that's one way that people have become addicted, through chronic pain. Stigma obviously is a consequence, and of course death is the worst consequence. But the stigma is serious because a lot of times people associate drug addiction with a homeless person in the street, when it could really, it really is everybody in society can be drug addicted, and so many people are. And people just like me and you that have jobs as nurses, doing whatever they're doing, drive nice cars, have nice stuff, whatever, are addicted, and you don't realize it because it's very well hidden. But it's really a pervasive problem in America. There's a lot of peer pressure for younger people, right? So take this pill, smoke this joint, but I have had grown adults come for rehab and say, yeah, I was about 30 and we were all out and we were all using all the time for recreation, and they didn't start using until they were in their 30s, which is, kind of at a point in life where peer pressure really shouldn't be as serious as it apparently still is. And that goes to lifestyle, right? People who are out partying, people who associate with other people who use, are likely to use. Another thing that is very important in the environment is oftentimes the person's partner introduces the drugs to them. So it could be a woman or a man being introduced by another woman or another man to use. I use, it's fine. Let's just get stoned tonight. I mean, it's really common when people start using from their romantic relationships. Marijuana actually is a gateway drug. I know there's been some controversy for that, but every one of my patients says that the first thing they did was smoke, and they will tell you that they felt that that led them to want to do other things, because the relaxation and the feelings that they get when they smoked, they wanted more and more of over time. You also have cannabis receptors in your brain that become, I don't want to say tolerant, but people get used to the high that they get from marijuana, and they want more. There's also coexisting, and this is a really serious condition, a real serious contributor to opioid use, is when the person has coexisting behavioral health problems, almost always of anxiety and post-traumatic stress, they're more likely to use. And I have to say that 99% of my patients, abuse is so prominent in this population. It could be abuse from childhood, but it could also be recent past abuse from a romantic relationship, or a relationship at work, or any relationship where the person is really abused by another person and traumatized and unable to negotiate that abuse or manage that abuse at the time it's happening. So it's really, and then post-traumatic stress sets in, then anxiety and stress, is associated with that, eventually can become panic. So to cope with all of those things, people turn to opioids. So that's a very, very, very common issue with people who have opioid use disorder. The comorbid conditions highly contribute to use, and they also pose a barrier to treatment. Because if somebody has anxiety, depression, I mentioned child abuse, but it's called, adverse childhood experiences. So that could be death of a parent, it could be death of a sibling, it could be an illness the person experienced as a child. Anything in their childhood can give a person post-traumatic stress disorder, eating disorders, and then we also know serious mental illness, bipolar, schizophrenia, those types of diseases also can contribute to use, but they also pose a barrier to use, right? The person sometimes has these behavioral health conditions. They're so prevalent that they're not able to actually go and seek out help and engage, and when you go for help, person has to engage, right? They have to participate, they have to take the medication, they have to show up for appointments. There's a lot of responsibility with being a patient in a drug rehab program. So sometimes these behavioral health conditions, if they're not treated, they actually are a barrier. On the last line here says MICA, which is mentally ill, chemically addicted. This is very common. Again, the patient has other illnesses and they're also chemically addicted. And if both aren't treated, neither one will get better. That sounds very easy to say. You will know it's not that easy to do, right? It depends on the resources in the community. Mental health resources in many places really aren't as strong as they need to be. There's 4 opioid receptors in I wrote 4 opioid receptors in the brain, but 3 really are prominent with drug use: alpha, mu, and kappa. The opioids can change the brain stem, which is an area that controls automatic bodily functions and depresses breathing. It can change the limbic system, which is the amygdala and the hippocampus. And that's where emotion and emotional distress occur. And so again, the motivation to use to really reduce the feelings in that part of the brain, calm them down, make them feel more relaxed, make them less bothered by the thoughts of trauma or whatever. Opiates can block pain messages transmitted by the spinal cord. And that, again, we said the original pathway into the use. So before we had a COVID epidemic, we had an opioid epidemic, and it was classified as an epidemic reaching national emergency status in 2017. But when you think about how long this has been going on, it probably should have really received that classification long before that. Health and Human Services then, as a result of the emergency, listed 5 national priorities. 1 was to improve access to treatment and recovery. 2 was to promote the use of overdose reversing drugs, which is Narcan. We're going to talk about that in a little while. Another is to strengthen our understanding of the epidemic through better public health surveillance. Another is to provide support for cutting-edge research on pain and addiction, because if we could find a non-opioid that could treat pain just as well, you would never again have to prescribe opioids for pain, right? And advancing better practices for pain management. There was legislation with financial support attached to every single one of these priorities, but the prevalence remains extensive. Now, 2017 was not that long ago, right? What is it, 5 years? But even before that, we were really addressing this, in terms of the government, right? Financing things in states and local governments. And the epidemic just keeps going on. In 2018, there was 67,367 overdose deaths. 2019, it rose to 70,630. In 2020, in 1 year period, and the period was measured in May, 81,000 deaths. And then 1 year later, 100,306 deaths, which, of course, you could blame on the COVID epidemic, but that's only a part of it. There's also a lot of non-fatal overdoses. So these are just the deaths, right? If you then factored in how many people overdosed, it's really not known for sure, because some people receive Narcan. So that overdose is not recorded. If the person's not brought into an emergency room, it's not recorded. So you could be in your living room, overdose. Somebody in your family can give you Narcan and nobody will ever know you overdosed. And this happens. Patients will tell me, I was Narcan 5 times, So, these are the people that have passed away from this. Sometimes before they pass away, they've had multiple overdoses. And with the fentanyl now, there's all of a sudden where I live, I don't know about every place in the country, but where I am, there is no heroin anymore. It's all fentanyl. And this is what the patients are telling me. So they're a little more frightened because fentanyl can kill you quicker. If the person overdoses from fentanyl and they don't have a pulse, which happens faster in fentanyl than heroin, you can't reverse it with Narcan. The person dies. So they're a little more scared now. So we're all of a sudden seeing, more and more admissions, thankfully. The legislation attached to initiatives was the Substance Use Disorder Prevention that promotes opioid recovery and treatment for patients and communities act, or also known as the Support for Patients and Communities Act in 2017 and 2018. A lot of money was put into those initiatives, and the Comprehensive Addiction and Recovery Act, called CARA, of 2016, and the Drug Addiction Treatment Act of DATA, right? That's the acronym is DATA 2000. That is where, there was legislation put in place again for treatment, for recovery, for prevention, and for treatment services. But, we're still seeing so much more. Money is not always the answer. A lot of times it really is the full community awareness. I think having more people aware of prevention is ultimately going to be the answer. We have accepted uses of opioid, which is pain management. We have coexisting behavioral health problems, and I mentioned marijuana before. There's also THC and kratom, which, kratom is something that people can take as a pill or smoke. And now with over-the-counter kratom and cannabis, that is THC. So you could smoke marijuana, or you could take, the CBD oil, and it's the same thing. Up here in New York City, marijuana was legalized for recreational use. So you can't step 2 feet without smelling it. It is absolutely everywhere. Even driving in the car, it's everywhere. All right. So, you see within a month how many people were smoking that we didn't even realize, and smoking under the influence now because they're not getting stopped. Nurse practitioner will see patients who are addicted to opioids in primary specialty, obstetrics, gynecology, urgent emergency schools, or anywhere. It is a complex issue. You have to treat the comorbid conditions because polypharmacy can rapidly become a secondary problem. So issues of depression and anxiety are often treated with multiple medications, but the symptom control of those are, again, a secondary problem. So these things have to really be cared for before you're ever going to get anywhere with the opioid use disorder treatment. Same thing with pain management. If the person has chronic pain and they're taking opioids illegally, you have to manage that pain. Something has to be done for that pain because that's going to just continue to drive them to use. The CDC did issue guidelines for opioid prescribing in chronic pain. And there's 12 recommendations, and they're essentially grouped into 3 categories. One is determining when to initiate or continue opioids for chronic pain. Another is opioid selection, dosage, duration, follow-up, and discontinuation. So there's guidelines on that. Another group of guidelines are how to assess risk and address harms of opioid use. Opioids for pain management should always be avoided except in select circumstances. And that really is oncology pain and things that are really where the addiction is really not going to be a big problem, but the pain is more the problem. When acute pain appears to be becoming chronic, which happens all the time, person hurts their back. Back is like number one, but person can hurt anything, knee, hip, anything. And, they're in acute pain, and then all of a sudden that becomes chronic. It doesn't go away. It's still there. That person within a few weeks really should be referred to a pain specialist because there are interventions that can be done to relieve the pain. But a person should never be left in pain. We all kind of agree on that, but the management is critical. So, whenever possible, we encourage the use of a non-opioid analgesics before even considering an opioid. Cognitive behavioral therapy can be successful in addressing the emotional discomfort associated with chronic pain. Remember that pain does take a huge physical toll. If anybody has ever had pain or watched a person in pain chronically, it really takes a toll. So it's not something you can just leave. Opioids for pain management, again, we said should be avoided except in select circumstances. Nurse practitioners really have a social responsibility to become part of prevention. And awareness is really important, right? Awareness is part of education with serious messages in places that count. So social media. Think of our daughters and all the young women whose lives we touch. They really are vulnerable. They need to really understand why it's so important to not pick up. That is a real important thing that, women everywhere should really be teaching younger women everywhere else. Remember, I don't know what everybody's memory is about the tobacco addiction, but there were really very dramatic television advertisements that showed what it was like to die from lung cancer or emphysema, or what it was like to try to live with respiratory disorders. Really dramatic, horrible, graphic advertisements, and that was used to dissuade people from smoking. And I believe that it did work. We also then had other things like Chantix and Wellbutrin and nicotine replacement therapies. We have some things like that for opioids, which we're going to go over later. But that type of awareness, that type of very dramatic awareness, can really dissuade use. Adequate pain management, of course, we mentioned. But if you're treating a person for pain, understanding the nuances of pain. What is acute? What is chronic? What is musculoskeletal? What is somatic? So you really can figure out what is needed to be done for the patient in terms of pain relief. So it helps assure the adequate prescribing of the adequate medication. Pain has to always be investigated. It can never be ignored. But non-pharmacological therapies are recommended for musculoskeletal, anti-inflammatories, hot and cold packs, something that's very, very, very helpful is physical therapy. And, exercise, things like that. But if you refer the patient who has musculoskeletal pain to PT, and it's a good PT, they'll work with them on things that they could do independently. This, of course, is really, again, talk about barriers, right? Insurance companies don't often pay for the amount of therapy a person may need. So again, assuring that the person is going to a therapist who's going to really work with them and help them manage their pain after a few sessions. During primary care visits, a nurse can take a thorough assessment, which will be more likely to capture each person's risk. In social situations, we see pain, trauma, psychiatric, all these things should be really assessed. Assess the patient's social situation, their pain, their trauma, mental health, all these have to be really included in the assessment. And also very, very, very important is the family history of addiction. We do see many families, many people where all the family members use something, all the family members use opioids. Often they're introduced to opioids by a parent or a sibling. So those family things are super duper important because it's not only genetics, it also goes to lifestyle, it also goes to environment. Oftentimes the person really can't get better unless they're physically remove themselves from the family. And that, causes a whole other set of emotional issues. There's some red flags for potential use, which we just said: personal family history of addiction, trauma, a diagnosis of PTSD, anxiety, and depression also fold in there. A lot of times those three things are one. The person has anxiety and depression from the trauma. Another red flag is a spouse or a partner who uses and requests for opioid to relieve pain. There's screening tests that you probably do, the PHQ-29 to identify depression, and the GAD-7 to identify anxiety. There's the CAGE, which is the alcohol use screening. But there's screenings, I'm sure you've used all of them in primary care to really determine if a person is at risk. So what we use for opioid addiction, and actually really all addictions, is the screening and the brief intervention and referral to treatment. So whatever screening tool you're using on your EMR or in your practice, you use, when you find the results, if the person screens as a high risk for opioid addiction, or really even any addiction, you have to use your judgment. You can't just use the tool, but you use your judgment with your full assessment, your physical exam, your person's history, all of the things that we've mentioned up to now, your full assessment, along with, the other risk factors: where do they live, where do they go to school, what other things do they talk about. All those things, along with the screening tool, can lead you to a diagnosis, right? You determine that a person is at high risk or actually has opioid use disorder. You can do what we call a brief intervention and referral to treatment. This is an evidence-based approach to identify people and engage them in treatment in a very short visit that you would have in primary care. So you identify the risk early, which allows for intervention. It should be part of every primary care person's toolkit. The substance abuse screening and up here in New York, it's really routinely completed in every primary care visit. So the patients can screen low, moderate, or high risk of becoming addicted, and recommendations really are based on I have women's here, but it's person's risk level and the drugs they're using. Good communication shows an interest in the patient's life and struggles, acknowledges the patient's reasons and perspectives about using. Once you get the screening results, you have to assess the patient to see if they're really ready to stop. And this is the number one hardest thing. A lot of times, it's like everything else in psychiatry. The patient has to be the driver and make the decision that they want to get help, that it's time for help. So you have to assess their readiness. Sometimes they just aren't ready to let it go. And could be, you're not most likely not going to find out why they don't want to let it go on a primary care visit, because you just don't have the time. But you have to assess if they do. A lot of patients, a lot of women particularly, are afraid that their children are going to get taken away from them. So that's a motivator for them. So back to, we see the next thing is motivational interviewing. That is the next step. You interview a person and you try to focus. It takes some practice, but it's a patient-centered way to interview to determine if the person wants to change and why they think a change is beneficial, and you explore options with them. So you have to kind of find out what's the motivator, right? Are they motivated to keep using, or are they motivated to stop using? And we're at whatever you see on the screening and part of your history, that's really what you talk about, what's motivating them. And the focus is to try to get them ultimately to go for help, right? So once you do that, you have other things you have to do. If they are sexually active, you really need to counsel them for birth control. This is for men and women. If they're using intravenously, you should really screen them for HIV and hepatitis. If you live in a community that has needle exchange programs, you can send them. Early identification and treatment of behavioral health conditions should be integrated into care, treating anxiety and depression. And the APN provider must consider initiation of treatment and take steps to secure an appointment with a behavioral health provider when possible. That's referring, right? So on the referral, you have to know what's available in your community. Shared decision-making, that is a model of care where the person and the provider make a decision together. So if a person's willing to get help, but they don't know where to go, talking to them about, do you want inpatient? Do you want outpatient? Like working with them and figuring out the best solution once you identify that risk is present is how you would use shared decision-making. And then if you have social services or behavioral health providers in your network, in your neighborhood, near the patient's house or wherever, you really want to try to get them into services that are convenient for them, because we'll know that when you see a behavioral health provider, it's not a 15-minute visit, it's a weekly hour. So they have to be able to get that into the rest of their lives and facilitate the access, meaning maybe, make appointments for them, have appointments for them when they leave, have your staff work with it, whatever it is that you can do to facilitate access. Now, medically assisted treatment is medication that can be given in primary care office or in a drug treatment program. It lowers the potential for a fatal overdose, so that we call that harm reduction. So the priority goal is to hopefully have the patient not use so much that they harm themselves, right? So that's number one, first and foremost. Then the other goals, prevent pregnancy, stop using, take care of the rest of your physical health, reduce the violence and conflict in the family. All of those things become goals that the patient identifies and works on themselves. But the priority for you would be to do whatever you can to make sure the patient doesn't harm themselves, right? So the harm reduction is important. It's important for you to know what harm reduction, things that are available in the community for the patient. Okay, so harm reduction is a proactive, evidence-based approach to reduce the negative personal and public health impacts of behavior associated with substance abuse at the individual and community levels. Most significant substance use and overdose epidemic ever is happening now. It's not getting any better. You could blame a million things. It doesn't matter what the reason is. It's each individual person's reason. Why we look at why that person is using and what you can do to help them stop. And then for nurse practitioners, I personally believe it's our social responsibility to participate in anything, any way that we can to on the prevention side. So this is there's a pandemic going on with COVID. Whether it's over or not doesn't matter, because we've seen a proliferation of highly potent synthetic opioids containing fentanyl at the same moment when the COVID pandemic occurred. So again, doesn't matter what the reason is. There's over 100,000 deaths, last year. There's probably going to be more than that this year, because it just seems like we're just seeing more. But fentanyl is fatal, right? And an overdose of fentanyl is often fatal. So it's really important that we look at harm reduction at home and in the community. So the 4 pillars of harm reduction strategy is accepting that if people are using, we have to accept this, all right? Because you're not going to be able to stop all these people from using. So we accept people in our neighborhoods are using, people in our families are using, our schools everywhere. Let's make the use at least safer. The goal, of course, is abstinence, but the other part of harm reduction is to meet the person where they are. and address the conditions of the use along with the use itself. So here's some goals and strategies for all four of those pillars. The first is to reduce the spread of sexually transmitted and other bloodborne infections, including HIV and viral hepatitis. We mentioned that there's often a misstep in judgment, and unplanned pregnancies and these STDs are prevalent. This is a very prevalent problem, so it's part of the pillar of harm reduction to increase knowledge around safer sex and sexual health. And that is, again, access to PrEP, HIV and viral hepatitis treatment, access to condoms, but comprehensive sex education. And if your client is a woman, there are many options for birth control that she may just not have gotten around to because she's very busy with the rest of her life. And then this, of course, is a priority problem. So you may be able to get her engaged with, intramural IUDs or intradermal transplant or a NuvaRing, or something that, she doesn't have to take every single day, but can, really reduce her risk of getting pregnant. I have to say that in my patient population, my women are all okay with that. That's kind of, I hate to say covered, but that hasn't been a problem. It's been a problem in the men. Almost all of my men have recently, within a year or two, gotten a woman pregnant. So, they have to be counseled as well. So you have to make sure you really talk with them about that. And you're not going to most likely ever meet their woman, right? Reduce overdose deaths and early deaths among people who use substances, including alcohol, increase knowledge around safer substance use. So we have had syringe and needle exchange programs. I don't know if you have them in all of your communities, but here you can, if you are using with needles, you can go drop your needles off and pick up clean needles. And they just also approved for safe injection centers. So you can, if you are using intravenously, go to an injection center, inject safely at the center and hang around there for a while to make sure that you're not overdosing. There's nurses. I really don't know the details of how they're going to be operationalizing that yet because it was just passed. But the goal is to keep people from dying from opioid use. And then once they get into a center where they're using, a safe injection center, there will be people there to facilitate or assist them into abstinence treatments. And then there's the Naloxone and overdose education kits so that overdose can be reversed, and those are prescribed and given to people who use and their family, as well as, first responders, but the lay people have them now up here. Another goal is to reduce the sharing of substance use equipment, improve physical health, and reduce, therefore then reduce the use of the spread of infectious disease. So again, the clean needle programs up here have worked, medical care, including wound care, because there's often injuries, especially when there's been violence. So caring for those things. And again, just like we've been doing now, using masks, social distancing, and vaccines. I'll tell you, I can only speak to my patient population, but my patients, almost all of them are not vaccinated. They're not working, so they haven't had to worry about their jobs, most of them anyway. But when I've asked them, why won't you get vaccinated? They're afraid of the vaccine. It's very interesting that they're afraid of the vaccine, but they're not afraid of the fentanyl and the heroin. It's an interesting thing to think about, like how this drives their lives and what other, things that they're kind of concerned about. They vehemently will not get the vaccine. That's been, and I know it because we ask our patients, and then we have to mask and have plexiglass and face shields and every other cool thing for the last couple of years. I'd like to let that down myself a little bit when I'm talking to a patient, but no, they're fully comfortable with a plastic bag over their head instead of taking a vaccine. Medication-assisted treatment is use of medications in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of substance use disorders. Medications used in MAT are approved by the FDA, and MAT programs are clinically driven and tailored to meet each patient's needs. So we're going to talk about those medications now. We have Buprenorphine, Sublocade, Naltrexone, Vivitrol, and Naloxone. So the first was methadone. This was a drug that started to be used after the epidemic in the 60s and 70s. It's a controlled substance too. It's a full receptor agonist, which means that it activates the receptors in the brain. So the patient thinks they have, or the patient has, because methadone is an opioid, have opioid, but it's controlled, so it keeps them from wanting to use. It relieves all the withdrawal symptoms, it prevents cravings, and this way the person can stay sober. So their desire to use is quelled by the methadone, but they are not stoned. So they can go to work, they can conduct themselves and their family and have a full life. It's administered, though, only through a licensed opioid treatment program, and it's regulated by SAMHSA, and the programs have to meet federal and state guidelines. It cannot be prescribed in an office setting, and the programs also have counseling, peer support, treatment of other conditions. The risk of diversion is great, right? So yeah, they have to have processes in place to prevent the person from diverting, but methadone can be bought in the street. Okay, abuse and overdose potential is reduced if they're in a methadone program. So it's not just methadone, it's the whole program. It can be used in pregnancy. It can't be prescribed in primary care, but you should know where the treatment programs are in their communities, as many people have recovered through a methadone program. Other resources available through these programs are an important part of treatment. That's the behavioral health thing I mentioned. So remember, there's recovery and sobriety, right? So if a person takes methadone or any other drug and they're sober enough now, they're not stoned, they're not running around crazy, spending half a day looking for their next dose. They're able to think more clearly when they're on one of these drugs. They can then engage in the full comprehensive program of treatment, which is therapy, which is peer support, which is counseling, which is family counseling, which is getting their medical problems taken care of. So it's very nice to be sober and not craving. But recovery is different from sobriety, right? So sobriety means you're not stoned. Recovery means that you're actually working on the issues that drove you to use. You're working on all your problems. You're working on improving your family relationships. So really the first goal is to get them to stop using illegal, dangerous, harmful substances. The second goal would be to get them to stop using anything. And then of course, to have a full life back. Buprenorphine is a partial opioid agonist, but it works as an opioid. So it's the same thing as methadone, but it's weaker. When compared with the antagonist or blocker, when combined rather with the antagonist or blocker naloxone, it's known as Suboxone. So it's an opioid, right? Buprenorphine is an opioid, and it's combined with naloxone, which is the Narcan, which is the antagonist, and that keeps the person from being stoned, allows them to be sober, and it reduces the cravings. This does not have to be given. This can be given in any medical office, unlike methadone, where they have to go and get it every day. You give them a prescription for a month, they can take it every day for a month, keeps them sober, and it is a really good drug for that. It does, however, have a problem with diversion. You know, if a person is taking, 8 milligrams twice a day and only needs 8 milligrams once a day, they can sell the other 8 milligrams. So we have to do UDS, we have to do, urine screening. We have to really judiciously prescribe it. For my program, I monitor them very closely. But, people get this in prison, it seems to be everywhere. So they'll come in and they'll say, oh, I'm on Suboxone, I'm on street Suboxone. I want to now become I want to go into recovery. I want to get it legitimately. I don't want to talk to these people anymore that are in the street. And, that's how I know, and that's how they, patients tell us these things, what's really going on with the Suboxone. So we know it's diverted. So you have to have things in place in your practice to prevent that from happening. So it should be combined with counseling. Again, I mentioned this multiple times already. You have to treat the coexisting behavioral health problems. It can be administered in an office setting. The person has to be in moderate withdrawal, though. You have to give it to them when they're starting to crave. That's the appropriate time. And then the prescribers have to have the 24-hour course to get the data waiver. A data waiver means that you've been, you're accepted into the group of people that can prescribe buprenorphine. It reduces the cravings. They cannot get high no matter how much they take. It has a ceiling effect. So it doesn't produce the feelings of opioid use, but it reduces the risk of misuse and side effects. And again, I mentioned before, it allows for continuous sobriety and the person can focus on healing. Before benzos and buprenorphine are contraindicated to be prescribed together, but we see people come in already addicted to benzos that they're getting prescribed from somebody else. So before co-prescribing, you have to ensure that the patients are appropriately diagnosed, that they really have opioid use disorder, and they really have whatever the benzos are being prescribed for. And consider alternative medications and non-pharmacologic treatments to address anxiety and insomnia. Every one of our patients actually gets a full psych consult. Ensure that other healthcare providers prescribing benzos or other substances are aware that they're taking buprenorphine so that you can coordinate care and minimize risks associated with concomitant use. Many of them want to see 2 different providers. So you have to really work together for the benefit of the patient. You have to take measures to confirm that patients are taking their medications as prescribed, that they're not diverting or supplementing. So again, that's why we do the tox screen, because we see what else they're taking. Here's how to get the 24-hour training course if you want to access that. And more information on Suboxone can be found at this website. Sublocade is the extended release Suboxone. It can be prescribed in an office setting. It's available only through a restricted program called the Sublocade Risk Evaluation and Mitigation Program. It's an intradermal injection that's given, and it's extended use, so it lasts a month or longer. The goal of the REMS is to mitigate, the REMS program is to mitigate serious harm or death could result from a person actually taking it themselves. So the REMS assures that it's only being administered by a nurse or a doctor, and the patient can't take it themselves, because if they give it to themselves intravenously, they can easily expire. It's a 300 milligram dose for 2 months, and then a 100 milligram dose. So it's a lot of Suboxone. It falls into a reservoir in the person's stomach, and that's how it's slowly released. But it's a lot of Suboxone. So if a person accidentally injected themselves, they probably would pass away. So that's why there's strict release on who can get it. When I have that here, the certified healthcare settings and pharmacies cannot distribute, transfer, loan, or sell. And here's more information available on Sublocade and the REMS program. There's always a risk of hepatitis, hepatic events in this patient population. So before you give them anything extended use, you have to really monitor their liver function tests before and during treatment. And you also have to understand that if they're dependent on any opioids, there's a withdrawal, right? So verify that they're stable on Sublocade, on Suboxone, before you begin to give them Sublocade. Intravenous injection, I mentioned this causes a serious risk. The other thing is that the Sublocade forms a mass if it becomes in contact with blood and body fluids. So it can make an embolism. So it could actually kill a patient. Occlusion, tissue damage, thromboembolic events. If any of this gets into the bloodstream as a pile, it could cause fatality. Injection site reactions are pain, erythema, pruritus, abscess, ulceration, and necrosis. And neonatal abstinence syndrome, of course, if a person is pregnant and they're on Sublocade, the baby will be born with NOWS, but it's expected and it becomes treatable. Naloxone is Narcan. This is the life-saving drug that restores normal breathing. It can be given as a nasal spray or as an injection. It's easily administered, and the lay public can be trained to take the Naloxone. So it's pretty easy and has saved a lot of lives. These are the labels for Naltrexone, which is not Naloxone. Naltrexone is a different drug. It's a pill. It's taken once a day, and Vivitrol is the extended monthly injection. So Naltrexone, when I talk about Naltrexone, I'm talking about both, right? Opioid antagonist, it fully blocks the receptors in the brain. It can be given by mouth or injection, and by extended release, it's a 28-hour injection. It eliminates cravings, prevents relapses. So it's a great drug because it totally blocks any desire to use. In order to have this used properly. The person has to be completely detoxified from opioids. So they have to abstain for 7 to 10 days. If you give a person naltrexone and they have any opioid in their body, they get an abrupt withdrawal. These drugs interact and they cause what's called a precipitated withdrawal. It can be a very serious condition requiring hospitalization. So we always make sure before administering that there's no opioids. So that could be with urine or serums preferred to assure that there's no opioid in their body before starting it. It's not addicting, so it presents no problem of abuse or diversion. It's not a controlled substances, can be prescribed anywhere. You do have to check the liver enzymes though before administering it. And you have to start with 50 milligrams once a day, the oral preparation to make sure the patient can tolerate it. And then they can transition to the extended use if they want. A lot of patients prefer the pill because they have more control and it's short acting. They could go off it if they have another health problem. Vivitrol is the long acting, it's once a month. And once you take something, it's in you for a month. The injection sites can have some reaction, pruritus, tenderness, induration, swelling, bruising. And they're more likely during an accidental subcutaneous or adipose layer injections. It's an IM injection. So if it goes into the subcu or the adipose layer, the person's more likely to get a reaction. Both preparations should be part of a comprehensive management program that includes psychosocial support. Our patients often go to the AA meetings, even though we have NA meetings. A lot of them prefer the AA meetings because those have been around longer and they find that the sponsorship for alcohol is more effective for them than the narcotics. But they have options and some go to both. But they have to be going to something because that's part of MAT, medication assisted treatment is assisted, not just the treatment. With Vivitrol, again, there's a risk of hepatotoxicity, so the liver enzymes have to be evaluated. It cannot be used in pregnancy, and the full product information is there. Patients have to understand the danger of opioid use when they're on Vivitrol, because sometimes they're on Vivitrol and they decide they want to use opioids. They don't feel the craving, they just decide they want to use it. So they wait for the 28 days to go by, and then they take the same opioid that they used to use. Now their tolerance has come down and they can overdose. Some of them try to surmount the blockade and take more than, because eventually you can overcome the block, but there's so much then the person will overdose. So they're vulnerable to a relapse overdose when the naltrexone is waning. After a month is over, they don't have any left in their body. That's when they're vulnerable to a relapse or an overdose. That's the dosing interval, right? So we have to make sure that they keep their appointments. That was something we take responsibility for. Should they use the previously tolerated dose? I mentioned that the fatal overdose could occur. Should they try to surmount the blockade? Again, the same thing. So if they take a large enough amount, it can be fatal. They have to really understand the risks of this. So when they commit to taking it, their responsibility is to come every month and to not attempt to get high. They should also have some Narcan on hand so that other people know how to administer, encourage them all to carry Narcan. The daily or extended release versus the oral is, again, the patient's choice. There's more controlled use with daily, more control with daily use, a better, a shorter half-life. They can stop it whenever they want. But it's really, some people who tend to relapse want the Vivitrol because it protects them for a month and it really keeps them from overdosing. So that's my presentation. Thank you very much for inviting me. This is my email address, and I'm available for any questions by email, telephone, or Zoom. And it was very nice to do this presentation. I hope you will learn something. Thank you very much.